Okay, great. I can kick things off. So welcome everybody. Thank you for joining tonight, and thank you for joining this interactive tour of the third endoscopy suite at the Dartmouth General. Before we start, as everyone saw when you entered, we are going to be recording this call tonight for the benefit of those who couldn't join the call. So if you're shy, just turn your camera off, but I encourage you to keep your camera on, and you'll be able to ask some questions as we go through. A big thank you to all of the donors to the Get Up There event over the last 2 years, and to all the participants. You made a difference, and we're here tonight to show you how much of a difference you made over the last 2 years. We're so proud to share the impact of this space that it's having on our patients and staff. And for donors and those of you from the Get Up There event for colorectal cancer, the equipment you're going to see tonight is here because of you and for no other reason. So thank you so much for your support. It's thanks to donors and supporters like you that this incredible third new endoscopy suite is a reality and is going to be helping patients. We're joined tonight by Dr. Chad Williams, a gastroenterologist at the Dartmouth General Hospital and a participant in the Get Up There for colorectal cancer last year, and our #1 fundraiser. Thank you, Chad, setting the bar high for this year. And also we're joined by Mark Gascoigne of Trampoline Branding, founder of GUT, Get Up There for colorectal cancer, and also a Dartmouth General Hospital Foundation board member. If you have any questions throughout the evening, feel free to ask. Also, we have the chat function that's on the side on Zoom. So you can just, if you're not comfortable in asking the question yourself, just put in a question in the chat function. Mark Gascoigne will moderate the Q&A after Chad's presentation. And Mark will be looking for those chat questions and help ask any questions that you have. Before we start though, Mark, do you want to say a few words about yourself?
Sure. Thanks, Stephen. What Stephen didn't mention is I'm also a Dartmouth boy, not just on the board, but
Dartmouth proud. Yes,
a Dartmouth boy. That I have a Mac Pass and I'm not afraid to use it. Like unlike a lot of my friends that live in Halifax. So. My day job is I work at an agency in Halifax called Trampoline Branding, and sort of more importantly is, as it pertains to this, is I'm one of the founders of Get Up There. And, Get Up There, we've been around, this is our 14th annual Get Up There. And about 3 years ago, we tag teamed with Dartmouth General, and it gave a whole new life to the event. It was doing okay. But one of the things that we have always been kind of our sort of raison d'etre is screening, colorectal screening. So there's lots of people raising money for cancer treatments in all different forms. And we decided the thing that we really wanted to sort of hang our hat on was the screening. And Nova Scotia, as many would know, have an amazing public screening program. But the problem is we have a choke point, and the choke point is secondary screening after people have had a positive fit test. So it just became a natural fit to see if we could try and alleviate that choke point. And this third endoscopy suite is the start of helping solve that problem. So especially proud of that association and really looking forward to seeing what we can do.
Thank you so much, Mark. You've made such a big difference, not just for Dartmouth General, but for the whole colorectal screening program. And thank you for doing that. Chad, over to you. How about, do you want to introduce yourself a bit more and also maybe give us the sneak peek into the third endoscopy suite?
Sure. Thanks, Steve, and thank you, Mark, as well. And thank you to all the donors and the participants that are on the talk today. So I'm also a Dartmouth boy, well, Preston, which is on the outskirts there, but still Dartmouth. And I do not have a Mac Pass, and everybody makes fun of me for that. But I actually haven't had to cross the bridge since they made this thing. I think it's electronic now, or since the rate went up. I usually just go around the basin because I live in Sackville now, but I should probably get a Mac Pass. That just makes more sense. So that's where I'm from, I did leave home for training. I did internal medicine and GI in Calgary, and then spent a year in LA doing inflammatory bowel disease. But as Steve already mentioned, I'm one of the gastroenterologists at Dartmouth General Hospital. And currently I'm the endoscopy lead there. That is a position that rotates every few years. And this is now my second year doing that. I am also internal medicine lead, site lead at DGH. A year that I've been doing that now as well. So I wear a few different hats. Those are just two of them. But I'm really, really thankful for the new space. I was here when I first came back home to work. The endoscopy space was not where it is now, and was not like it is now. This is really state-of-the-art facility. The third room adds a whole other dynamic to what we're going to be able to do with regard to meeting and even surpassing standard of care with regard to colon cancer screening for Dartmouth, yes, but also for the zone and for the province. So it's a pretty big deal, and it's well equipped with state-of-the-art tools, and the space is phenomenal. Nice space, large space that makes it much more amenable to patient care and for us getting the work done that we need to do, and it's well resourced. With regard to the Get Up There campaign, I will be climbing this year. I actually didn't climb technically last year. The Get Up There campaign always falls on a Friday. Friday is always my endoscopy day. So I was actually doing colonoscopies. But what I did do is I videotaped myself doing a rather rigorous HIIT, routine, because you guys were all, doing a very rigorous walk around. So I did do that, raise some money for that, and was happy to be able to contribute that to the pile for our team. So that was great. And I will be joining you this year. I was able to swap my endoscopy day this year with one of my colleagues, Dr. Fleming, who's also going to be fundraising. So she was a little bummed that, one of us had to scope. But I twisted her rubber arm. And she agreed to let me do it this year. Maybe she'll do it next year. So that's what we're doing with regard to that. But what I'd like to do now is kind of just share with you. I'm going to share my screen here. What I'd like to do is share a bit of where this generous funding went last year. I'm just going to make this a little bigger for you all. Away. Great. Are you seeing that okay? Head nods, yes. Okay, good. So this is the tour. And it's going to be, chaperoned by yours truly, as you can see. And this is kind of through the patient's eyes. This is how the patients kind of enter and then leave the endoscopy suite. And I'll talk a bit about each step of the way. Sorry, guys. Need to start at the beginning. That would be a good thing, right? Good. So this is where folks just walk in. You can see there are some chairs here. They approach the front desk. Right now, we moved it out of the way for the purpose of the picture. And I don't know what's going to happen on March 21st, to be honest with you, it'll probably still be there. But there's actually a divider here, a glass divider in between patients and the receptionist. Usually Alicia, who sits here, she's excellent. But nice space there for folks to come up and be greeted and be instructed about, when they're going to be seen and who's seeing them that day. That's just another shot from the same space. And then after that, they walk in through the double doors and they then see this, which is a big nursing station. This station is in the middle, and surrounding it are patient beds. So the nurses are able to see patients from every angle here. So this is both the intake, so the pre-procedure space, and then in the back where you see these kind of beige curtains, that's the recovery area where after patients have had their procedures, they recover briefly there, maybe get a little snack, and then get to hit the road and go home. This just shows you, so this is one of the areas where patients are waiting for their procedure. So big space. This space we didn't actually have to close it down significantly during the pandemic, mainly because of all the space. You know, there's definitely the ability to do distancing, social distancing with this kind of space, and not all endoscopy suites for sure have this ability to do. Certainly the space that we had previously on the main floor of DGH would not have been able to accommodate this because the space was not anywhere near this size or generous. And then, you know, we enter the room. So this is what the third room looks like. Actually, all of our rooms look the same. And what I'll highlight here for you is some of the really neat and important vital pieces of equipment that were donated by the monies from the funding. So basically, almost everything you see here is from the DGH Foundation, except for this stretcher, not part of it. But basically everything else came from foundation money. So certainly the third room space in and out of itself. But if you look really carefully, you'll see over on the left-hand side, kind of a tower with some what look like computer modules there. So that's our tower, our CPUs there. This is you know, really high-tech and really expensive endoscopy processor. It's attached to a long kind of snake-like tube. That is the endoscope, actually. So that could be a gastroscope or colonoscope. This one's actually a gastroscope. It was just put there for the sake of this presentation. I'll talk a bit more about that instrument in a moment. But what you might notice is if you look at the tower itself, that big white thing kind of hanging down from the ceiling, it looks like it doesn't have any legs on the floor. That's because it doesn't. It's actually hanging from the ceiling, which is excellent. And that's not something that we have in other endoscopy suites in the province. So that's great with regard to space, saving on space. But the other thing is safety, because previously there would be cords lying all over the floor and there would be potential and risk for injury and accidents to staff. So that's not something that we have to worry about now. All the cording and wiring is up through the ceiling. And you can't quite see it, but if you look over to the right, that boom system is connected to the screen. And you can see that kind of dropping down off of the ceiling as well. This is a large, high definition, state-of-the-art screen. So we have 3 of them, and the third room's equipped with one as well. Allows us to see things that we wouldn't have seen with previous technology. So that is excellent. And there's a little handle, little silver handle off to the left of that screen. And this screen rotates 360 degrees around. So because we do different procedures in this space, as it's currently drawn up, this stretcher with the pillow near the far end of the wall is actually set up for a colonoscopy. And that screen's almost in the right spot for a colonoscopy because the endoscopist would be in between the big tower, the CPU, and the stretcher here. So that would be perfect. But if we do gastroscopy, the setup is slightly different and the screen would be in a slightly different angle and orientation as well. So those are the big money items there, but also the cabinetry, I should mention, is funded through DGH Foundation. And just a piece of architecture here that I wanted to point out, in the very back of the room, you'll see a little door here. It's really cool. It's a little cubby hole that opens up. That allows the ward aides to actually pass the used instruments through the door to a central area where these instruments are processed and cleaned. Previously, what would happen is the ward aide would actually have to take the scope, the endoscope, out of the room, walk it down a hall to the cleaner, and just a lot of extra steps, a lot of extra time and efficiency. And time is really important when we're doing these procedures. So that little innovation there. Each one of our rooms has this door into the cleaning space. Great idea. This just shows you everything from another angle. You'll see off to the very left here, there's another metal cabinet and a metal desk there. What you can't see is there's actually a computer system and a physician's station there as well, and that's where we would do our report. So very efficient and spacious area. Yeah, this is just a glamour shot, I guess, of the same space. I'll pass that. This is so this is the recovery area. So very much like our intake area, there are a few stalls here, stretchers. There's no chair because the patients actually get rolled right in on the stretcher that they had their procedure done on. Nurses will attend to them and they'll get The nurses who are in recovery will get information from the nurses who were in on the procedure about what happened, how did it go, what medications did they require, is there anything we should know before this patient goes home, does the patient have the proper reports and supports before heading home. So that's all taken care of in these stalls, and then the patient's discharged home thereafter. If I need to speak to a patient after a procedure, I may come and see them here, but as you can see, it's not very private, right? So it's not really built for that. We do have in this space, though, just down the hall, just across from the nursing station, a private area, a private room with a door that closes if we need to have more intimate, private conversations about things that may have happened during or may have been discovered during the procedure. Last slide, or second to last slide, and I'm sure this is going to come up because people want to, what I've shown you is where the money went last year, and that's phenomenal. The other thing I should say here, let's move off of this because I don't want to get you distracted. One thing I didn't say is that, that third room is really, really important. And Mark already highlighted a bit that there's a bit of a choke point where, yes, people are getting their fit tests, but there's a bit of a loggerhead where they're not necessarily getting their colonoscopies as quickly as we would like. And there is, a certain benchmark within several weeks, usually within 4 to 6 weeks, we like to be able to get somebody from positive stool test to a colonoscopy, and that's not happening. And part of the reason that's not happening is because we don't have enough endoscopy space for that to happen. This third room will change that. The idea will be when that third room opens up, and that will be imminently, to run it 4 or 5 days a week purely for colon cancer screening. And the reason for that being just for colon cancer screening is that that's where the funding is for the human resources. So, yes, the foundation provided all of the capital resources, which is really, really important and imperative, but the scope room doesn't scope on its own, right? So we need nurses, which are probably the most important part of the whole setup. We need nursing staff, and they need to be paid and scheduled accordingly. And so the colon cancer screening program, the provincial screening program, has put up the ante for that. And we marry the two, the capital and the human resources, and we have the third room online. So that's how we make this all work. It's going to be the workhorse for colon cancer screening, really for the province. What you may not know is Dartmouth General Hospital is already the workhorse for the colon cancer screening program for the province. Our hospital does more screening colonoscopies than any other hospital in the province, and that's only going to increase once this third room opens up. And that's a very, very good thing. It will get us closer to the benchmark that we need. So back one, because everybody wants to know what was that piece of machinery. So this is pretty cool. So if you focus on the right, kind of looks like a cable box, maybe an old cable box, because the new ones are much sleeker than that. But this is much more high tech than a cable box, much more expensive than a cable box. This is a device called GI Genius. And what it does is it uses artificial intelligence, or AI, and it is able to use pattern recognition, looking at the walls of the colon. So you'll see over on the side, looks at the walls of the colon and identifies certain, we call them pit patterns. So it has pattern recognition that can identify whether there are probably polyps there or not. And that's great. You may say, well, why would you really need this? Aren't you guys trained to look for polyps? And what did you go to school for if you need a box to tell you if there's a polyp there or not? So you're right. We've done lots of great training. These polyps that they're showing on the screen here would easily be seen by me and any of my colleagues. But what this device is able to find is ones that are far more subtle than that. And what the data show is that this device can find up to 17% more polyps during colonoscopies than a really, really good endoscopist could find on his or her own, which is important. And I'll tell you, there's nothing more aggravating. There's a couple of people, I think there's at least one nurse on the call that does endoscopy, gonna get up there with us as well. There's nothing more frustrating than having somebody show up for a FIT positive test. You've done their colonoscopy, you bring the colonoscope all the way back out very, very slowly, and you found 0 polyps. And then you go back up because you're frustrated, you feel like you should find one because the test said that there's blood there. and you still find 0 polyps. What would be really great would be to have a wingman or a wing woman like this box there that's able to kind of confirm whether there's absolutely nothing there. And sometimes, folks have hemorrhoids or other reasons for bleeding that's caught by the test, or whether you did miss something. And, it will light up with a green or a red box and give a little beep if it thinks there's something there. And then you can have a closer look at that area and really scrutinize it a bit more. If the box says there's something there and you don't see it, maybe you're the problem, and you need to look a little closer and blink the eyes a bit. So that's GI Genius, and this was put forward by one of my endoscopy colleagues, Riley Stewart, to DGH Foundation as an innovation, and this is where the money will be going for this round. This is phenomenal because of what I've told you. The other thing that's phenomenal about it is there is no other place in Canada that is using this currently. It is FDA approved, so it's being used in the US, not in a whole lot of spots yet, but it is being used in the US, and it's bona fide and data proven. But Dartmouth will be the tip of the spear with regard to artificial intelligence utilization in colon cancer screening in the nation. So we're already the envy of our I will tell you that they were really excited about this and really wanted us to maybe pump the brakes a bit so that they could maybe get in on some of this action. And we were very happy that they were very excited, and we fully support them in approaching their foundation. And I'm sure the QE2 Foundation will be just as generous as DGH has been for us with regard to this. So we're going to run with it. And by the way, this isn't just a DGH. We don't just serve DGH patients, right? We've got patients who come from all over the zone. So this will be a benefit to everyone, and we'll be able to get some really great data off of this as well. So if you haven't noticed already, I talk a lot.
This is fantastic, Chad. Really great. Thank you so much for sharing this.
I'm going to stop that. Yeah, I'll stop sharing and kick it back to Mark.
Great. Thank you very much, Chad. Amazing. This is the first in Canada. That's incredible. So I'll turn it over to Mark Gascoigne to moderate the Q&A. Mark.
Sure. Thanks. Yeah, Chad, listen, I'm very happy because, we're going to be walking up and down Citadel Hill half a dozen times. I wanted to know what that money was going to be spent for. So thank you very much. Very enlightening.
You're welcome.
I have a question from Anne Janega, and she would like to know, what is the relationship between DGH and the IBD clinic at the VG?
Yeah, me. In a short answer. So the IBD clinic at the VG is run basically by Jen Jones, one of my IBD colleagues. Actually, I trained when I trained in Calgary. Well, backing up a bit, Jen's from here in Nova Scotia, so she was a senior resident when I was a med student, and we followed each other around a bit. So when I was a GI resident in Calgary, she's just returned from the Mayo Clinic. Super smart lady. And she was a junior staff there, and now we're both back here. So we were actually the only two IBD docs here for a time, and now Mike Stewart, also a Dow grad, also traveled through Calgary and also traveled through Cedars-Sinai, where I did my IBD training. You can see we try to travel the same routes. He's here now as well. So there are 3 IBD physicians in Nova Scotia. The IBD collaborative clinic is run out of the VG, but technically all of us are able to kind of utilize the resources that are there. So I hope that answers your question. So, what's the relationship between DGH and the IBD clinic? The DGH itself doesn't have a connection to the IBD clinic, except for its connection to me as part of that group. I think a really great idea or question would be whether we could kind of have a satellite IBD clinic at DGH. We're getting off track from colon cancer, but my other real passion is inflammatory bowel disease, Crohn's and colitis. And what many of you may know, and some of you may not know, is that the hotspot for inflammatory bowel disease on the planet is Nova Scotia. We have more inflammatory bowel disease per capita than any place else on the planet. Nobody knows the exact reason for that, but it's true. And so that means that IBD is a huge issue here for us as Nova Scotians. And we need to work harder to try and improve quality of life for those patients as well.
Thank you very much.
Thank you for that.
Great info.
Darlene and I actually have the same question, and that is, I'm kidding. Will the GI Genius better detect multifocal flat plate dysplasia?
Good question. So it should. So those types of lesions have different tip patterns. Like the mucosa just looks different. The issue though is, to the naked eye, and depending on the way the light may hit, what type of, if you're using just plain white light or what we call narrowband imaging, where you're kind of using different wavelengths, a polyp may, become more apparent or not, may pop on the screen or it may not. And so what this technology is using is a bunch of different filters and software algorithms to identify patterns, to kind of say, wait a minute, stop, I think this fits with this particular pattern. You should look at this area more closely. So yes, it would, what I would expect it to, I haven't used it, Darlene, but what I would expect it to find are those types of polyps that make us as endoscopists say, oh, wow, I wouldn't have seen that without this machine, or, I could have easily have missed that without that machine, things that are subtle, but still important.
Thank you. That would be great for that to be able to be detected. Just from my own personal experience, when I had my scopes in Halifax. So for instance, the multifocal flat plate dysplasia was one of my diagnoses, but there was only so many of them. And my GI doctor suggested, let's wait 6 months and do another one. And if I could have avoided that 6 month wait, you know what I mean? Like, I hope for somebody else that could be detected sooner. Yeah.
Well, so let's just answering that and digging into that a bit more. So with inflammatory bowel disease, the type of dysplasia that you get with, say, ulcerative colitis, sometimes it's very scattered, and sometimes it's not, coalesced in a polypoid type of shape. So this machine would probably pick up something that's, low-grade dysplastic polyp that's super flat, not really obviously visible to the naked eye. But in a patient with inflammatory bowel disease, they may actually have some high-grade dysplasia within that, and that thing could grow. Patients with IBD can get cancers without having polyps, which is not the norm. Now, if you just have, high-grade dysplasia here and there, and, things that are just found on biopsies, microscopic type of stuff, that's not coalesced into a pattern or into a polypoid type form, I wouldn't expect that this machine would find that degree of disease, something that's microscopic. It still needs to be something that's large enough to be a pattern.
Okay, thank you.
Yeah, you're welcome. What we do though, and you've probably seen it, Darlene, is we've got all kinds of other ways to identify that kind of stuff, including using special dye on the colon and narrowband imaging. Yeah.
I just asked
you, Darlene.
I guess,
go ahead, Bob.
Can I ask? Okay, great. I'm probably one of the bankers in the group, so the question I have will always typically center around money rather than health first. I was, amazed to hear Dr. Williams that this facility services us province-wide. So my question is, do we see donations coming in from other communities? I know we have the gut fundraiser, but do we see donors from other communities across the province that we've reached out to say, we have this capacity, so we'd appreciate your donations?
Yeah, great question. So, and I'll answer a bit, and I won't answer your question altogether, but I think Steve has a bit of the answer there. So sure. When I say that, our facility serves the province, that's because it's a provincial screening program. So all the facilities that do screening actually serve the province. So, the VG site serves the province, Dartmouth General serves the province, Bridgewater, Kentville have endoscopy suites and they participate in screening. And, when they do that, they serve the province. The differences are that we do a larger proportion of those screening cases than anywhere else in the province. And that's for multiple reasons, I think. We have 3 gastroenterologists which I think is actually too few for, the type of GI work that we need to do outside of colon cancer screening at DGH. But we've got 3 who are really, really hard workers and enjoy being part of the program, and they're all part of that program. We also have several general surgeons who are also really hard workers and enjoy being part of that program. Not all the other sites have that kind of people power to run these rooms. And we also, by the way, we also get endoscopists every now and then coming from outside of our site to participate in the screening program, and we welcome them. I think patients first. We have to, do this together and work together, and I think we learn from each other in doing that as well. Your question though about donors and, are there donors from outside of Dartmouth or outside of the zone that are putting money into the pot for these great initiatives? I don't know, but
I can answer that one, Chad.
Yeah.
So this one, especially Bob, is very relevant for a donor outside of the zone, which is the John and Judy Bragg Foundation are actually matching every dollar this year raised and supporting this new GI Genius initiative. So the John and Judy Bragg Foundation, they've established an innovation fund for Dartmouth General. And for this very reason, they're seeing things that are being started in Dartmouth and then roll out across the province as standard of care. I see Dr. Natalie Cheng has joined the call as well. So maybe I'll get Natalie as the chair, as our lead physician on the Innovation Committee to talk a bit about the Innovation Committee and that fund. Natalie.
Yeah, this has been a phenomenal donation for our site. I think over the years we have gained a reputation for being really versatile and open to innovation, and a lot of projects have actually started at Dartmouth General and then gained recognition. So we're kind of being identified as this innovation sandbox, and so this was really timely to have this John and Judy Bragg Innovation Fund, and it's going to be driving innovation. Before we had lots of ideas and no resourcing for these ideas, so everybody was trying to do these innovative ideas on the side of their table with no funding, and that really limits really puts some pretty big walls around what you're able to do from an innovation standpoint. So this has been transformative for us.
Excellent, excellent.
Well, thank you very much, Natalie. Thanks for the question, Bob. And I think, I don't know if Chad did it on purpose, giving a plug, calling it a cable box, that it's John and Judy Bragg.
Good one.
There you have it.
That was not intentional, but it worked.
Please, any more questions, fire them my way. There's none in the hopper right now, but I'll fill the blank with
there's one in the chat there.
Chad. Oh, is there a question?
Yeah, there's.
I think I can see it. It's from Jenna Joyce. So the question is, will the GI Genius be used for all colonoscopies going forward at DGH or just for certain candidates? Great question. So that GI Genius will be in the third room, which will be the one that is going to be doing most of the colon cancer screening cases. There will be colon cancer screening cases that obviously may be done outside of that room as well, but the majority of them will be in that space. So the short answer is no, it probably won't be used for all people going forward, at least not yet. And there are a couple of reasons for that. Because we probably won't be moving the box around from room to room, and it may not be top of mind necessarily if somebody's being done in room 1, for instance, and the box is in room 3, and somebody's already in room 3 doing screening cases. Sometimes, as Mark was saying, or I think he mentioned, even after we've taken polyps off on somebody and they come back as part of a secondary run for a colonoscopy, but they're still technically being screened, right? They've got a family history or they had polyps a few years ago and they need to come back. That person may not be done in the third room. They may be coming back on my personal list because I'm following up with them, and they may be coming through, in room number 1 or 2, and so that we don't have boxes there. It's the hope that Dr. Riley Stewart and I were talking about this just yesterday, that once we get going with this, we should probably have all the boxes in all these rooms at some point. But the other thing I wanted to say to you, Jenna, is we already provide, even without this box, we already, with our colonoscopies, are providing the standard of care. So I want to be clear with that, because I think without saying that, people may get the perception that, oh, well, if, you know, Dr. Williams is using this, you know, GI Genius on this person, but he's not going to use it on mine, doesn't that mean that I'm not getting great colonoscopy? No, it means you're still getting a really good colonoscopy. You're getting, you know, the standard of care. What it does mean, though, is that we're using this extra technology that will probably be standard of care at some point in the not too distant future. But you're still getting a great product. And screening guidelines may actually change based on this artificial technology. You know, we bring people back every so often after they've had polyps because we want to make sure they haven't grown any more polyps. But if you've done a colonoscopy with one of these, the data may show that you could even prolong the time to bringing them back, which would be really, really important with regard to, obviously, nobody wants to do a colonoscopy, they don't have to. And then with regard to resources, you know, you can redirect those resources to folks who haven't had a colonoscopy yet, but ought to. So I hope that answers your question, Jenna. The answer is there will probably be people who go through screening who won't be used or be also surveyed with GI Genius, but I suspect that in the years to come, it will be part of common practice and probably part of standard care.
Thank you. All right, thanks for the question, Jenna. We have a question from Tracy Mitchell, which is you've partly answered. You talked a bit about weight line, but there may be some other factors that you haven't disclosed yet. And her question is, how does CT colonoscopy help with your colonoscopy wait lists?
Yeah, you know what's interesting is Steve and I had a chat, just a hallway chat about an hour and a half ago. So we were talking with one of my radiology colleagues. He was in on this chat as well. And the question was asked, what's better, a colonoscopy or a CT colonography? And we both laughed and kind of, you know, gave each other a bit of a stare. And I kind of said, well, the politically correct answer is these modalities complement each other. And, you know, there are some patients who do better with this and with that. But then my radiology colleague, you know, he perked up and he goes, well, the standard of care is still colonoscopy, which is true. So for this particular indication, if we're looking for polyps, the standard of care is still colonoscopy. And that's because there are lesions, not dissimilar to some of the lesions I showed you on that picture. Those flat lesions, you're not going to see that on a CT colonography necessarily. They're too flat. And they're not easily seen. CT colonography is great for ruling out other major lesions. You could argue that the ones I showed you on the pictures weren't necessarily ones that were going to cause any trouble in the kind of short to medium term anyway. But CT colonography is great for, you know, more significant lesions. And where I tend to use CT colonography in screening is not in most people, but it's in individuals who are special in that they have difficulty maybe tolerating a colonoscopy, or we've attempted colonoscopy on them multiple times and they've had multiple surgeries or they have the adhesions. It's really tough to get around the bowel with a scope. Sometimes, you know, in individuals who are concerned about undergoing conscious sedation, because we often provide medications for the colonoscopy. If they don't want that, but they also don't want to do an unsedated colonoscopy, well, then we're kind of hooped. But they would opt for, you know, the CT colonography. But in most algorithms, CT colonography is not part of the base of the screening program, and it's for that reason. The other thing is CT colonography doesn't provide a way for us to remove polyps, right? And colonoscopy does.
Right. Thanks for that. And just a clarification, because there's a lot of terminology being thrown around. Your GI Genius is used during a colonoscopy as a second set of eyes, correct?
Correct.
Yeah.
Right. And I don't know if so to answer, the question was regarding wait lists earlier. So it doesn't, CT colonography doesn't significantly change our wait list. And you know, to be honest, I probably ordered a CT colonography maybe like for screening purposes, maybe 2 or 3 times, less than 5 times a year for sure. And that's it usually in somebody who I just wasn't able to get around on, or, you know, one of the other scenarios that I mentioned.
Right, great, thank you.
Yeah.
Darlene is curious, as many of us probably are, is when is this thing going to be put to work?
Yeah, Steve, when are we getting this? So Riley's
Well, we've
been on it.
approved it this morning, so in the board meeting this morning. So Natalie, I'm not sure how long it takes to get this installed. I know.
Just put it up on the capital equipment request. I think
Okay.
today, so it's rolling quickly.
We're meeting with Medtronic tomorrow morning at 9 o'clock, so we'll ask them that question as well. So I know they're really keen to get this happening at Dartmouth General.
Yeah, sounds like the answer is it's in the mail, but they need it. Yeah,
It's in the mail.
And the room itself, though, the third endoscopy suite, when is it operational?
I mean, yeah, so I think all we need to do, so you were in, I think, Mark, on one of our meetings we had maybe 3 months ago with Don McIntosh. And, you know, certainly from my perspective and from the colon cancer screening perspective, they're ready to go. They have the money ready to go. So, I mean, I think imminently, and I don't think we need to wait for GI Genius to come by, to get that going. No. It seemed like it was more of, so pandemic is just now coming to a place where we aren't necessarily relocating or redeploying staff. So it's a staff issue, right? So we need those nurses to be able to run that room. So I think once that's the major issue, is having the nurses to run the third room. Once we have that, then we're good to go, because the colon cancer screening program is going to fund the nurses for the screening program for that third room.
Right. Okay. Any other questions out there from anybody?
That's great. Well, thank you very much. Mark, tell us a bit about the event itself coming up on April 1st.
Then he went back to
Sure. I feel like I should put Jackie on the spot here, but I'll do it. No, I'll do it. I wouldn't do that. Jackie's had a long day. So on April 1st, as I said, it's going to be Get Up There's 14th running. And we decided to do Citadel Hill again for the second year for some obvious reasons. It went well. And, we were a little late out of the gate this year, as everyone was wondering what was going to happen with the Omicron variant, but we felt pretty comfortable about a month ago and we kind of pushed go. So we already have, I think, 10 or 12 teams, similar amount of money raised to date, similar amount of participants. So we're expecting to have, I think we'll surpass last year, but essentially it starts at noon and everybody just starts walking around Citadel Hill and down to the waterfront. And we do that until we're tired or pass too many pubs and just can't pass them.
That's fantastic. So thank you, Mark, and thank you for taking the time to ask questions. And thank you, Dr. Williams, as well, for sharing a glimpse inside behind the scenes in an endoscopy suite. And this third endoscopy suite will make a big difference for sure. So please, everyone, sponsor a runner, sponsor one of the teams. Dr. Natalie Cheng and Dr. Williams are our co-captains of our DGH Above and Beyond Climbers, our Dartmouth General team again this year. So please reach out. Darlene's running again on our DGH team. Dr. McQuarrie, I see him there as well, also a member of our team. Please reach out and sponsor.
I just posted my fundraising link into the chat. I got there first.
Oh,
go for it.
Jenna, put our link in there.
Oh, we can spread it out.
You can spread it out. Donate to multiple teams. As Dr. McQuarrie said in the chat, Dr. McQuarrie, I think, set a record for our team for the number of rounds. There's Dr. McQuarrie. Wave, Don. Dr. McQuarrie said that you're on mute right now, but I know you said you're climbing because you're a son of a survivor. You want to tell your story,
That's
Don?
right. What's that?
Tell your story. Tell us your story.
Oh, so my mother had colon cancer and was found with I think she was a diagnostic. She was having some symptoms prior to a screening colonoscopy. But anyway, so she's well. She had a good outcome, and again, I see in the emergency department, much like Chad, we see people with late outcomes at times that are wholly avoidable if we can find the cancer early. So I'm looking forward to running as well. I don't think my son's running with me this year. He'll be at school, but last year, I think, or 2 years ago, I think I tried to chase Joe Eisner around Wentworth, and I couldn't keep up with him. So last year it was just me. I got 9 times around. I'm hoping this year maybe Chad and I will split the 10, so he can do 5 and I can do 5.
I'll bring my Venolin. How's that?
Sounds good, man. I'll see you there.
And I don't have Venolin, but I might need to.
Thank you very much, everybody. This is a very important cause, and for me, myself as well. My mother is a survivor thanks to early screening of colon cancer, and she's now just turning 90. So it makes a big difference in everyone's life. That's why I'm climbing for our team as well. This year, again, every donation is being matched dollar for dollar by the John and Judy Bragg Foundation to help bring this GI Genius first in Canada. We're so excited to see this happen. So thank you, everyone. Come out and cheer the team on, donate, and we'll make this a bigger year this year. Thanks, everyone, and have a great night.
Excellent
Thank you.
presentation. Thank you.
Excellent.
Thank you.
Dr. Williams.
Thank you.
Chad.
Thanks.
Thank you very
Thank
much.
you, everyone.